Good morning, everybody. We are not too many yet, but I hope people will come and all the minute will have more participants because this is going to be very interesting session organized again in cooperation with European Bifurcation Club. We are really happy to have here the chief of European Bifurcation Club, Goran Stankovic. Thank you, Goran, for coming. And we have also our strongest guys from EBC, Maciej Lesiak and Robert Gill. And we would like to thank again Robert for organization of this year EBC meeting in Warsaw. And we have also very strong panel, Paweł Buszman, Bernardo Cortese online, Andrzej Zerglis, Mirosław Ferenc, Michał Hawranek, Otach Linomas, Sylwia Iwańczyk, Paweł Kleczyński, Łukasz Kołtowski, Zoltan Róża, Łukasz Rzeszutko, Adam Witkowski, all friends, we know each other, so I hope we will have also some discussion during this session. And without any further delay, I'd like to ask our master, Professor Goran Stankovic, for the keynote lecture, Left Main and Bifurcation PCI Optimization in 2024, European Bifurcation Club Perspective.
Yeah, good morning, everyone. And first of all, thank you very much for the kind invitation and the kind words. It's really pleasure and privilege. I think, except for Greece, this is the second country that I visited the most time during my career, and I feel really home when I come here. And thank you for the invitation to participate again. I hope it will become a routine practice in the future. Few general slides just to mention that for more than 10 years, European Bifurcation Club is promoting provisional sideband stenting as the default approach, including the left main, and we try to describe the steps of provisional as we see it as a progression of steps in the latest consensus on stenting techniques. So when we speak about optimization, we need to discuss first what are the steps and how we progress from one step to the other, and we try to make optimal stent expansion and deposition following the fractal geometry of coronary bifurcations. So the only two mandatory steps are step number 1 and step number 2. Step number 1 is crossover stenting, selecting the stent according to distal main vessel diameter, and step number 2 is POT. After that, we evaluate the result, and if the result is good for most bifurcations, available evidence says we can stop at this point. We don't need to proceed. But if the result at the side branch is not optimal, then we proceed to step number 3, which is exchange of wires. Step number 4, kissing with or without final pot, and then we evaluate again. And if the result is still not optimal for the ostium of the side branch, then we go to step number 5. And just for your information, indications for step number 5 are different among the studies. And for example, we currently use for left main EBC main criteria, which means TIMI3 less than TIMI3 flow in the circ, severe ostial pinching, but really severe, 90%, or threatened side branch closure like dissection. This is the current state-of-the-art approach to provisional side branch stenting. So wire both branches, predilate only the main, consider imaging and lesion preparation, stent the main vessel according to distal diameter, and perform POT. After that, for left main, we recommend to rewire the circ and do kissing balloon, first sequential and then simultaneous, and then you stop to reapprise. And if the result is good, you stop. If the result is not good, then you proceed to provisional side branch stenting with T-tap or culotte. But in that case, kissing becomes mandatory, and final pot is recommended again as a mandatory step. Of course, for diffuse and long side branch disease and high risk of compromise or difficult access, we recommend upfront plan 2-stent strategy, but again, we favor provisional approach, finalizing procedure with T-tap or culotte. And for the left main, based on the available evidence, of course, we accept DK crush as a valuable option for operators with the appropriate experience. And we describe the steps in the second part of the 16th consensus document. I'm not going into details, but strongly suggest to read this because we really describe not only the steps, but also potential pitfalls and the troubleshooting. And this is the provisional pathway, which is based on estimated risk of side branch closure. If the risk is low, we suggest to do provisional, T-tap and culot. If there is a major concern regarding the occlusion of the side branch, then one option is to go directly with DK crush, the other one to do inverted pulot, stand from left main into the circ and then do T-tap or preferably culot. Very brief update on the key trials presented in 2023. David Hildig-Smith at EuroPCR presented 3-year results of the EBC main, and you may see that at 3 years of follow-up there is still no difference in cumulative death, MI, revascularization, no difference in mortality or MI, but there is now statistically significantly lower rate of repeat revascularization with provisional compared to two-stent strategy. And if you see the Kaplan-Meier curves, you see divergence of curves. So by 5 years of follow-up, we don't expect the two-stent strategy will convert to better outcome than the provisional. And we also analyzed 3-year outcome for specific bifurcation, specific events like procedural or sudden death, peri-procedural MI, definite probable stent thrombosis, or type 4 MI and TLR. And there is, again, at 3 years of follow-up, significantly lower rate of composite bifurcation endpoint compared to two-stent strategy. And Giuseppe Tarantini also presented 2-year outcome of the Rolex registry, and in the Rolex registry you see that at 2 years of follow-up, target lesion failure rate was extremely low, only 5.8%, with only 3 new events compared to 1 year of follow-up. So if you follow the steps of provisional, you don't need to decide in advance whether you need 1 or 2 stent strategy. You go progressively, and approximately 1/4 or 1/5 in the left main of patients may need second stent as part of the provisional strategy. But key information that we learned also from the Rolex is that image guidance compared to angio guidance further decrease the rate of events, and I think it's very worth to put in the perspective. Bernard Chevalier also presented non-left main KISS trial. He compared after POT, no side branch intervention versus kissing or pot side pot, and primary endpoint just peri-procedural rate of myocardial infarction, and primary endpoint of non-inferiority was reached even with significantly lower event rate in the no intervention compared to control. We need to wait for 1 year follow-up to see if this will translate in difference in clinical outcome. EBC has published several documents dedicated to imaging and physiology guidance for bifurcation PCI, and now at ESC, updated network meta-analysis really confirmed the benefit of imaging. And there are 2 studies this year, Renovate Complex PCI and the October, which really documented benefit also in bifurcations, because the strongest subgroup in Renovate was actually left main PCI. But if you look the protocol of the October, you see detailed explanation of the steps for image guidance. However, if you look for the optimization of angio guidance, there is absolutely no data to confirm. So at EBC, we discussed this year how to optimally perform angiography-guided bifurcation PCI if imaging is not available, which is more frequent than we expect. So first, we need to understand that bifurcation is a 3-segment complex structure, and we have 3 separate diameters, and those diameters should be actually targeted and diameter decided by QCA, not by visual estimate. Especially we favor use of dedicated QCA because it's more reliable, since there is a step down at every bifurcation point in the reference diameter. Second, we learn from Phantom that OCT reliably determines minimal lumen area, while use of IVUS overestimates minimal lumen area in Phantom, and MLD in patients by OCT compared to IVUS we consider that OCT reliably estimates, but if we use IVUS actually again overestimates by up to 9 or 10%, and if we do QCA underestimates compared to both OCT and IVUS. So we believe that according to GUIDE DES trial, we should upsize by 10% for smaller vessels than 3.5 QCA measurement of the reference diameter, and less, maybe plus 5% for bigger vessels like the left main. And this study is extremely important because in GUIDE DES, QCA guidance versus IVUS guidance did not show any difference at 1 year composite of cardiac death, target vessel MI, and TLR. And if we look bifurcation subset and left main subset is the same. So the authors concluded that for all comers with DES, QCA guidance is non-inferior compared to IVUS image guidance. Few data on bench testing that presented this year at EBC. How should we select stent size for provisional crossover? This is, I think, the table that everybody knows with on-label maximum expansion capacity. And this is famous paper by Nicolas Foan that was actually showing that you can still overexpand. But this year, Gerard Finet and Derimay presented real maximum overexpansion going up to 7 millimeters. And you see that from current generation, actually, Science, Nagomi, and Synergy have the highest expansion capacity above 6 millimeters. And how can we explain? We can explain probably by the highest number of crowns and peaks. And Nagomi and Synergy have similar number also peak-to-peak design. Should we size the stent always in the left main based on distal reference? Hikichi showed that if we go for distal reference, for example, in the upper row, if we use Nagomi 3.0 according to circ diameter, then we see in the last image that actually we don't have good coverage in much bigger polygon of confluence. So he suggests to go with the proximal diameter 4.0, deploy it at only 5 atmosphere 3 times, and then perform POT. And you see that it's much better coverage at the area of bifurcation. And also, if you go for kissing, you see that with smaller platform, you again have distortion and malapposition in the polygon of confluence. So these are really pitfalls of selecting stent according to distal main vessel diameter, and this is one solution again based on bench that we should go different. How to optimally perform POT? We know that we usually start from the carina side, and this is the, again, bench. If you start from the carina side, you will see that by inflating from the carina side, when you are going towards the proximal edge, you actually elongate the stent. You see distal, and then he inflates, pulls back balloon, and by pulling back balloon, you actually longitudinally deform the stent. And this is extremely important for the left main PCI. So you see that we have elongation that can be seen by imaging, and you see also distortion in this most proximal part of the segment. On the contrary, if you go from the proximal edge first, if you fix the proximal edge, for example, ostium of the left main, you will see now that there is no difference in the length of the proximal part of the main vessel stent. So now he will inflate balloon first proximally, fix it at the ostium, and then he goes towards the carina. So this is just bench test, but I think that if we discuss how to optimize, this is potentially one of the ways to perform, and you see much less stent deformation within the left main. Stent position, very nice and very simple POT puff sign was again presented. So when you inflate balloon for POT, if you want to see that it's adequately sized, you inject just a few cc's of contrast, and you see if the POT balloon is adequately sized, you don't have distal flow. And you can also use in bifurcation stent enhancement software, so without dye you can see expansion of the stent. last important aspect is mechanical properties of the stent and balloon. So balloons are elastic but also plastic, and these are the curves when you inflate between nominal and rated burst pressure the first time. You don't even reach the diameter that is recommended. But with second inflation, balloon diameter becomes bigger. With third inflation, it becomes much, much bigger. So very early you achieve a big expansion. And you should keep balloons for at least 30 seconds. Important message also, to deploy stent of the current generation, you need less than half atmosphere. So it's a very fragile structure, and we don't need high pressure to deploy the stent. So, dear colleagues, I would like to conclude that we need to respect fractal geometry of bifurcation and 3 diameters. We need to use dedicated QCA instead of visual assessment if we don't have imaging. For left main, you can use Finet formula. Balloons are plastic and elastic, so inflate at least 2 times 30 seconds to reach the target diameter, or 3 times to compensate for undersizing by QCA. And there is no need for high pressure for deployment. We need to better prepare the lesion. For left main stenting, you can select stent according to proximal diameter, 3 times 5 atmospheres, and then pot. Stent apposition can be verified by small contrast injection or stent enhancement, and the same steps can be used for 2-stent strategy. But again, I would like to say that this proposal is valid for every bifurcation PCI, especially when intravascular imaging is not available. Thank you very much for your attention.
Thank you very much, Goran. As always, great presentation, very practical. In the sake of time, we will go on with talks, and we move the discussion at the end of this session. So now we move to another very important topic as for left main stenting, which is the role of imaging. And this topic will be presented by Professor Gil Robert. Please.
Thank you very much for this invitation. This session is really very important, mainly from practical point of view. And as we know from our practice, the repetition is a second nature of the human being. We should, let's say, repeat many times just to optimize our results. Today, my task is just to present the role based on evidence intravascular visualization. There are 2 techniques, intravascular ultrasound and optical coherence tomography. Let's start with IVUS. Of course, we know very well, and in the first step, I would like to show you that we have 2 aspects of evidence. Clinical evidence that is translated into the clinical aspects, outcome of the patients, based and build the scientific arguments to do or not to do a particular technique. So with the IVUS, we are able to assess the lesion severity, the real size of the vessel, the remodeling of the vessel, and reconstruct the 3-dimensional structure, which is a coronary vessel. We know also that with the help of this technique, we are able to collect predictors of drug-eluting stent failures, underexpansion, early thrombosis or restenosis. We know it quite well. This technique can be used pre, during, and after the percutaneous intervention, which means in every step of the procedure we should extract information just to be sure and to optimize our next steps. We know very well from many trials, this is one of them, ADAPT, showing how important from a practical point of view is IVUS usage. The proper sizing the balloon, other devices, the improvement of final lumen, stent lumen area, additional stent implantation, all of these information can be given to you when you decide to use IVUS. In terms of left main, which is one of this is the most important bifurcation in a human being coronary tree, we know quite well that there is a quite good correlation between functional assessment and minimal cross-section area. We know that for Caucasians, these 6 square millimeters means important value as a cutoff criteria. But we should take into consideration that in Asian population that are smaller, this cross-section area is lower, up to 4.8 square millimeters. So therefore, taking into account all of this information, we should remember that we can defer the procedure on left main when we have minimal lumen area more than 6 square millimeters. We should proceed with the intervention when there is 4.5, and in a gray zone, sometimes we need to let's say to repeat assessment usage using functional assessment. We should also remember that there is proper steps to assess left main. We need 2 pullbacks, one from left main, from left ascending left descending artery, anterior artery, and the second from circumflex artery. Then, just to avoid some jumps and assess the linearity and axial visualization. Taking into account the fact that bifurcation, that the three-dimensional structure, which consists of 3 parts, we should remember that this Kang criteria 5, 6, 7, 8 it's important. It translates into the final and late outcome of the patients, because under expansion of the stent, let's say, makes a very big difference. However, we should also remember that propagated by European Bifurcation Club provisional T-stenting also should be taken into consideration, because cross-section crossover stenting of the left distal left main changes the shape and the lumen area of left circumflex artery orifice. And then it's very important to assess these values before the stent implantation. These 3.7 square millimeters for the orifice of circumflex artery and plaque burden more than or bigger than 56% means potentially the need of a second stent implantation, or at least necessity to improve the orifice. If you take into consideration these evidence-based data gathered from many registries and trials already mentioned by Professor Stankovic, we should remember that there is still the benefit of IVUS usage versus angio guidance. Here you can appreciate two trials. The Rolex, this Italian Rolex, was already presented. There is no doubt that the properly performed IVUS assessment say makes a difference. And of course, there are a lot of trials showing that this benefit and superiority of IVUS guidance exists. We should take into consideration these facts. Not only the fact that IVUS guided PCI is better compared to angio, but we should also look at the let's say, precise data, very strong endpoints as death or composed complex endpoints as cardiac death, myocardial infarction, and tardive lesion revascularization. But this trial was a fantastic, showing that this is not a problem just to make an IVUS. The problem is just to properly assess and take into consideration and use the data given by IVUS. So this trial showed that the fact of performing IVUS, it's too less. We need to let's say, to use the data, improving the final results. Of course, there are many trials already completed as renovated or October, but this is another one, the optimal, which probably gives us strong evidence about the power and necessity of IVUS performing for left main. Here you can appreciate how precise, how meticulous is assessment of every part of bifurcation before and at the end of the procedure, just to gain optimal results, which is translating into the clinical outcome of the patient. These data from Excel trial showed us that this meticulous work, optimization, not just only the fact to perform the IVUS, means a difference. And this assessment by Mehara showed us that the bigger the better still exists. This is a very strong formula, and if we really work strongly on the optimization, the final results translates into the better clinical outcome, not only on complex endpoint, but also for a singular as death, as myocardial infarction, and stent thrombosis. So therefore, we know that today the KANK formula 5, 6, 7, 8 is too less for Caucasians. We need much more. We should add at least 1 square millimeter, and even with this 1 square millimeter, we are not sure that we are on the safe zone. But at least we should work. We should let's say assess the real size of the vessel, as trying to optimize to the real size, not just based on angiography. So taking into account all of this information, we can ask the question, why this is not a class 1? We're still waiting for this decision, maybe because of the political reasons and economical make this thing difficult. However, we have also the second visualization technique, which is OCT, and with high IVUS definition, these differences are not so big, but we should remember that the resolution of the ECT images are 10 times better. In terms of calcium assessment, it's much more precise. So for distal left main, there is no contraindicator to perform OCT. The problem is with the proximal part of this structure. Of course, we have less trials. We still have to collect data on the left main with OCT. However, for example, this ROC2 study showed that the clinical value is very similar to IVUS, and we should do that instead of IVUS. The other bifurcations, non-left main, we have also a lot of trials and registries showing that the superiority of IVUS over the angio exists. We should remember that that this assessment is not just only for immediate result, but also it translates for longer longer follow-up, 3 and 4 years. And of course, here you can appreciate a couple of other trials showing that this benefit of IVUS guidance for other non-left main bifurcation exists. This is not a matter only for left main. What is also important that we have already a lot of evidence showing that IVUS and OCT are almost equal in assessment of other bifurcation treatment, still over the angio-based guidance. What is also very important that OCT is much more precise in the field of non-left main bifurcation over the IVUS. So with the proper strat insertion for wire for side branch, the assessment of side branch with OCT is very, very precise. We should keep it in our mind. Just to summarize my presentation, in terms of plaque assessment, the real size of the vessel, the plaque characteristics, remodeling, we should remember about that, and we are able to use this information, taking into account possibility of IVUS or OCT measurements, and we should remember that it translates into the a better outcome of our patients. Thank you very much for your attention.
Thank you very much. Thank you very much, Robert. Great talk. Now it's my pleasure to invite Andris Erglis, my colleague and friend, to discuss pros and cons for IVUS in left main and bifurcation PCI. Andres, please.
Good morning, dear chairmen. Thank you to having me here. Thanks, Derek. Thank you, Jacek. It is great, and it's very difficult to talk. It's like in weddings. If you are one of the last speakers, then it's very difficult to say something new. But I tried at least to put some points. And it was very well described what's happening now, and it was in past. But I'm still, and actually we are 20 years. I have history with Krakow course for 20 years, and we are talking about imaging. And I guess that this is a year 2023 is really one of the breakthrough, because we are much closer now to imaging usage. But nevertheless, that's why I'm friendly, but disagree with Professor Goran Stankovic, because of course we can say that if we have no possibilities to use, then we should do something. But actually we should get possibilities to use imaging. And this is the point what also I guess we need to prescribe and to go. But if we go back, you know very well how it's went, and it's coming from, as I said, 15 years, 20 years ago, and with Spark published the first data, and then there was so many registries. Also in Latvia we have registry more than 2,000 at that time, and it was in 2012. And this is true, and Goran, of course, as usual, very well described what's happening now, and as you see, there is so many data about intravascular imaging. But the one thing, and this is a really important, and that's what I know, we do around 4,500 PCIs in our center. And actually, this is at least now I put one of the rules, which is very difficult to implement it, at least 10% to do with imaging. We have no limitation for imaging usage. Of course, maybe it will be in future, but not now. And as you look also here, you see how mixed is the data. There is no just left main. It's also bifurcation. It's completely different things to do even complex bifurcation, and also to do left main. It's really different. But nevertheless, of course, we have a data. We have a very nice data, and if you know, if we go back, and also yesterday was touched about some, I mean, meta-analysis include 2022, then now in 2023, really we have new data. And if we, for example, to look on innovate complex PCI, then you see how good is imaging guided PCI instead of angio guided. And also if you see of left main sub-study, then it's even much better results. And for this reason, we should again and again, and that's what Robert says, of course, to talk about and how we can, or how we can to move this on class 1. About October trial, I agree with Goran that there is some questions, but nevertheless, Riga also was one of the includers, and of course, I guess that it is like transition trial to next hypothesis to prove, but also if you look here, then you see that OCT is doing very well, and there was just 20% of left main lesions. If you look on Octivus trial, but this is an old one, it's quite old, it's published now, but Park, there was a Duwu Park, they started in 2008, and OCT guided, or I was guided, there is no huge difference. I am slightly disagree practically, from practical point, and we use very, I'd say many tools for imaging, like IVUS, OCT, different kind of OCTs, different kind of IVUSs, and also NIRS technology. And I'd say one thing also, we are mixing. I should say that we are mixing. It's 2 megahertz, 20,000 megahertz IVUS. It's not the same as 60 megahertz IVUS. And this is again, nobody talk about that, but this is actually again and again, we are very far from real usage of imaging. Also, if you look, you see, but there's a very promising data. If you see from this meta-analysis, which is done for 80 randomized trials, then you see that imaging is better than for left main than just QCA. I'd say that we have a real big database also in Riga, and for example, in different studies, we did more than 3 kind of, or even 4 kind of evaluation of lesion as CT scan, even 5, and with functional as well, IVUS and OCT. But that's also Robert touched, and it was very, very important. If you use IVUS, if you use every imaging, if you use even this dedicated QCA, you should use this properly. It's for sure, it's not enough to do pullback. So many times I'm seeing on very big meetings, people are doing for golden tubes, for gray tubes, for different kind of colors. They do a lot of imaging, but actually they can't analyze this. And then they're saying, yeah, everything is good. No, there's not good. Use of imaging, and as you see, actually, this is still very, very low, and that's I understand why you touched, why Goran, you touched and this point, if we not to use. And there is a different questions, but that's one thing what I really want to show. This is, you see, people ask to answer a question, they ask for 31,000 operators. Response rate was just from 1,000. You see, this is again what we should think about. About IVUS, I always say that we have IVUS. This is a very nicely see that you can think that you are young, doesn't matter that you have IVUS, but if you not use IVUS, you are losing this IVUS. First of all, better outcome with IVUS. What is the adoption of IVUS? Of course, it is lack of IVUS equipment, cost, time, lack of training, lack of experience, acquisition and image reading, some clinical scenarios. I agree that there is some clinical scenarios, very tight lesions and unstable condition, then you should save patient not to go for pictures. And in conclusions, I want to say it has taken more than 2 decades to gather evidence in favor of imaging-guided PCI, which has been shown to improve clinical outcomes and in numerous trials. However, IVUS remains heterogeneous and often low outside of trials. It is time to adopt imaging-guided PCI in the real world. The only way to develop and maintain an IVUS eye is to keep using IVUS. This is my really favorite picture. You see, everyone looks on Gioconda's eyes, but this is a detail. Of course, the detail is also sum of details, but we should not lose this big picture. Thank you so much.
Thank you very much, Andres, for a very interesting and exciting presentation on IVUS. Now this is the time for Professor Łukasz Kołtowski. Your topic is pros and cons for OCT in left main and bifurcation PCA.
Thank you so much, ladies and gentlemen. As it was said, it is very difficult to talk when you talk last, but I would like to be pretty pragmatical and practical on this. So there are different imaging modalities that we are using for planning, and that includes also CCTA, but for really intervention, there are only 3 that we can use, and I will focus on obviously on OCT because that's the main topic of my talk. I think the key aspect is the quality of the imaging with OCT, and it was criticized in the past, as I remember, and I really love that we see now a kind of agreement that OCT can be used in left main. However, without a good contrast flash, it is actually impossible to have good image quality. And to do that, there are a couple of things we need to remember. Number one is to have a coaxial position of our guiding catheter. The other aspect is a good feeling of the flash. It should be a lot if you use an automated syringe, but actually if you use a manual syringe, we should be flashing pretty gently. If we overflash, we will not get a good result. And the last thing, what we see is that if we are using a bigger catheters like 7F, we have much better chance of a good image quality. And this is, I think, a big drawback on the other hand of OCT, because we are now using a lot smaller catheters, I think, and we are trying to minimize the access. So therefore, this causes less of a quality for the imaging. Therefore, OCT really can be used for the mid-distal left main, but a no-go is the proximal part of left main, I think. So this is a definite minus for OCT. But if we look at the differences between OCT and other modalities, especially including IVUS, obviously the calcium is the big difference. As you see on the left side on IVUS, we basically don't see across the surface of the calcium. However, OCT is beautifully allowing us not only to understand that there is calcium, but also understand different types of calcium, including superficial calcium, deep calcium, nodular calcium, whether this is eccentric or concentric calcium. And that impacts heavily on how we perform our intervention. Calcium is now being evaluated also with new generation of OCT consult using AI, and this AI really saves time. We're talking that OCT drawback takes time, or imaging drawback is that it takes time. This software allows you to quickly understand the distribution of calcium and the arc of calcium within seconds. So this is, I think, a big plus for OCT and a Pro. The significance of calcium drives usage of debulking devices, and none of the debulking devices will be useful for long term if it doesn't work in the short term. And OCT beautifully can show us whether we have done a good job or whether this job has to be repeated. And therefore, I think it explains why imaging helps us during the intervention, and not only for final check, but also during the staging. The OCT is criticized that it cannot be used in people with chronic kidney failure, and obviously this is a big cons in this growing, I think, population of patients. However, we should remember that we can perform OCT imaging with dextrane or normal saline, especially in the right coronary artery. So that's one of the images from my experience. This is a gentleman with NSTEMI and CKD treated with imaging, and as you see, the quality of the imaging using normal saline could be pretty good. As we discussed left main, one of the biggest issues with left main is that about up to 30% of left main stenting shows malapposition if it's done only based on angio. And as you see here, we have a very nice criteria that were described already 4 years ago regarding malapposition criteria for cutoff, what we should ignore and what is clinically significant. And I especially draw your attention to the length of the malapposition, because actually OCT is the only modality that in an automated way allows us to nicely measure that. If we do a manual IVUS pullback, this is difficult. Now with automated IVUS pullbacks, we can have that measurement as well. But many of us are using manual IVUS pullbacks, and this manual IVUS pullbacks does not allow us to measure the length. To do a good job, we need to follow a step approach and understand what OCT will bring us at different steps of the procedure. And I think a very important thing is not just to use imaging for showing how beautifully we've done the job, but actually for planning. As we plan, we can expect to understand the plaque characteristics, the landing zone, the length of the lesion, the MLA, and the proximal and distal landing zones. And that will impact our stent sizing. That will impact also our choice of the pod balloon sizing. And frankly speaking, before we decide what stent to put and where to put the stent, we should ask what is the length of our minimal pod balloon that we can use, and OCT will help us to determine exactly where we should land. Once we have done our stent implantation and we go for the rewiring, which is not always needed, but if we go for that strategy, IVUS will show us nicely where's the wire and how we should where the wire went, and if needed, the impact of that of our PCI is that we can always do a wire repositioning. And I think this wire repositioning is critical. As you see here, a wire going under the struts, especially in the proximal part of the stent, because that will completely ruin our intervention. When we do the 3D reconstruction of bifurcation, we can nicely see the ostium of the side branch and wire position, whether this is distal or proximal strut that we have crossed through. From October trial, what we've learned is that actually about 50% of cases have wrong wire repositioning, wrong wire position, and that should be corrected, and OCT nicely shows us where the wire goes. And finally, for the last step, OCT run will confirm that we have good expansion of the stent, we don't have any malappositions, and whether there is or there is no dissection. And only with this confirmation, we can finish our procedure. And again, from October trial and from the recent analysis that we've done, we found that lack of last pullback is a risk factor, significant risk factor for MACE, and MACE is twice as high in those cases where the final pullback has not been done in this 2,000 patient trial. We know, and we spoke about evidence, and there is a lot of evidence already discussed, and I just want to drive your attention to this meta-analysis that wasn't published, but it's been shown by Professor Stone at ESC, where clear evidence from 20 studies, more than 12,000 patients, shows we have significant improvement, not only in, let's say, invasive cardiology endpoints, but also 25% reduction in all-cause mortality. And I think this is absolutely amazing. For the sake of the time, I will not discuss the last slide, and thank you very much.
Thank you, Łukasz. Great talk. And I believe that we should discuss maybe for a few minutes. First of all, we are not here to maybe debate OCT is better than IVUS, but just to remind everyone that we have new data published this year confirming that the use of intravascular imaging is helpful for our patients. And of course, in particular subset of lesions, which is left main, then there are some pros and cons for both. And maybe we can summarize these differences when because IVUS can be used in every case, I believe, but OCT, in which cases, Maciej, in your practice?
Yeah, as for the left main, I'm still stick to IVUS because there I have more experience, more data, clinical data, and so definitely for osteal lesion it's difficult with OCT. That's the point. But in other cases, in my practice, I love using OCT for bifurcation. It gives you a lot of important data. You can assess, for example, from the main vessel pullback, you can assess the status of the ostium of the side branch, which is not easy with or impossible with IVUS. If you change your thinking with OCT and stop doing angiography just for angiography, but you do angiography together with OCT, then you can really save contrast, and you don't, after the procedure, when you do OCT in only one projection, you don't need to repeat projections LAO, RAO, with wire, without wire, so you really can save some contrast. So because the amount of the information that gives you, OCT gives you, is huge. So if you don't see any dissection, edge dissection, any malapposition, or under expansion, you will never see it on angiography. So this is why I love OCT for these indications. For left main, still I'm based to IVUS.
Okay, so maybe it's a good time because we had the beautiful lectures for 1 hour, so maybe it's time to go to CAD-Lab. And for the next 30 minutes, we wanted, to perform left main PCI, trying to be as much as possible according to European Bifurcation Club rules. However, we've heard also some new informations from Goran in the beginning of this session. So I'd like to ask all the panelists and of course chairmans to make notes during the demonstration, and then of course afterwards we can discuss the most important issues, what we did wrong. We are here to teach each other. So let's go to CAD-Lab.
Good morning. My name is Łukasz Niewiara, and this is my pleasure to present the case of imaging-guided left main PCI. Our clinical case is a 70-year-old male with arterial hypertension, with dyslipidemia, diabetes, obesity, with COPD. After prior intervention in his both right and left coronary arteries, he has been admitted to our center because of CCS2 to 3 angina. Lab work revealed some mild anemia with some decreased renal function, and patient has been considered as high bleeding risk. His left ventricle ejection fraction was 40% without any significant valvular dysfunction. His right coronary artery revealed no significant stenosis. However, in the left coronary artery, you might see some severe narrowing of distal left main that has been considered in intracoronary IVUS and with some extensive calcifications. During heart team discussion, this patient has been considered as left main coronary stenosis with extensive calcification and syntax score 24 points. His treatment recommendations from syntax 2 was coronary artery bypass graft or PCI. However, considering obesity, COPD and frailty, this patient has been referred for PCI of left main.
Good morning, everybody. It's my pleasure to welcome you to the CAD-Lab at the John Paul II Hospital. My name is Jacek Legutko, and I have a pleasure to do today's case with Professor Paweł Kleczyński, Dr. Łukasz Niewiara, our nurses, Agnieszka and Dorota, and our technician, Adam. You have seen the case presentation, so this patient is high-risk patient with distal left main stenosis. And now we can see today's angio. We have started with spider view because what we are interested in mostly is just the ostium of the circ. In this view, it's not very easy to be assessed, but it looks like maybe the ostium is not very tight. Next projection. And this is epicranial, the best view to see the distal left main stenosis. Of course, it was assessed by angiography as ambiguous lesion, and as you have heard, it was checked with intravascular ultrasound. The lumen area was around 4.5 square millimeters, and this is why the patient now is on the table after heart team discussion and final qualification for PCI. LAD is excluded, but we see only very distal part of LAD, no good vessel for possible bypass grafting. And as for now, we are mostly concentrated on left knee disease, and then we can discuss what to do with the LAD. You clearly see these stents which are implanted since the ostium of LAD up to the distal part of the big diagonal branch. And now the next projection. And again, we see now the stenosis in the left main is not so tight. However, still we see a lot of calcium there. And we see the ostium of the CERG. Of course, it's not very conclusive in regards to the assessment of this ostium. And this is why in such scenario, we can, of course, discuss how to treat this patient, what would be our strategy for left main PCI. However, what we did is just intravascular imaging. So we use high definition IVUS, and you can see the probe is now in the proximal LAD. You see the stent is very well expanded. Of course, there is a lot of calcified plaque out there, maybe a little bit under expansion in the ostium, and you see that the stent is partially protruding across the circumflex to the left main, which is somehow difficult situation in this case. Distal left main is heavily calcified, and the plaque is protruding up to the aorta. So now you see the pullback, which we did from first obtuse marginal branch. Of course, diffuse disease, but not narrowing. And here is the bifurcation of CERC with first marginal branch. And in ostium, of course, we see the plaque all along the vessel with some calcifications in the ostium. However, it's not very narrowed. So, of course, we can again discuss, should we use upfront two-stent strategy because we have plaque there, or maybe we can try to do provisional stenting strategy. We did some measurements, and this is the proximal LAD. And as you see, the average lumen area within the stent is around 3. However, of course, this vessel is much bigger. It's around 4.5 media to media diameter. And we have seen this, this is really positive remodeling here, but at least 3.5 stents should be okay. Then we can see the distal left main. Okay, and this is the confirmation. Really, distal left main area is around 4.6 square millimeters, so we have tight stenosis there. And what is also very important, we have circumferential calcification here, so definitely this lesion needs to be well prepared before stent implantation. And now we can move to the proximal reference in the left main. As I said, and you can see that the plaque burden in the proximal part of left main is still 60%. In very proximal part is less, but this is very close to the ostium. So it means that, and this is the calcified plaque there. So I believe that the appropriate strategy is to cover whole length of the stent. And the media to media diameter is more than 4.6 4.6 millimeters. So I believe that the balloon for pot can be 4.5. But before we go for stent implantation, our decision is to start to do it provisional. So stenting from LAD to ostium of the left main with some overlap in the proximal LAD, and then pot with 4.5 non-compliant balloon. However, before stent implantation, we would love to perform pre-dilatation, first 3O balloon, just to enhance delivery of the IVL catheter, because in this patient, our strategy of lesion preparation is IVL. We do not believe that we will achieve controlled pre-dilatation with very high pressure balloon, and having this stent in the distal left main, which is not well opposed, I believe any kind of ablation would be not appropriate. So by this assessment, our choice would be to do IVL. So we have our 4.0 12 millimeter long IVL catheter, and I will try to position it just with overlap, which we check with stent boost. Then we are really sure that we are in the left main, Pavel. We are touching with the marker the stent. We know that the proximal edge of the stent is in the left main, and we see that we cover all the calcium which is in the distal part of left main. So please inflate 4 atmospheres. Okay, went back, so we will do here first. Of course, all the time we will see the pressure, and this is the problem with the left main, that we can have some hemodynamic compromise, but you see that it is possible. So we did first 10 pulses in the left main with some jump towards the LAD. So now I will try to go a little bit more distal. And Pavel, if possible, try to do it again here. Give 4. I will try to keep this position. This is low pressure inflation, so I hope it... Oh, now it's much better, you see? And we are doing again. If we give some pulses to the ostial and proximal LAD, it's not so bad because the stent was underexpanded. You see that this balloon is fully open. 6 atmospheres, deflate, and we need to wait. Maybe now we can give some contrast, Pavel, to be sure that everything is okay with circ. Yeah, it's good. We are in LAD, but it's not so bad. LAD media to media is 4.5, so still this balloon is not too big. And we will prepare this calcification, which is out of the stent, and definitely we will cover this with our drug-eluting stent. So I administer again 10 pulses of IVL. At 4 atmospheres, the balloon is fully opened. Okay, 6 and stop. And maybe now we can go to spider. So now we are in a spider view and we can open again. And as you can see, the balloon is again fully opened. So we will administer another 10 pulses of IVL, 6, and deflate. So we performed intravascular ultrasound, and this is the pullback from LAD. We see this stent, and in the proximal part, it looks like it's better opened. However, the most important is what we will find in the ostium of the circumflex. You see some calcium cracks there, and especially distal left main. You see this is after low pressure balloon dilatation, and now the lumen is much bigger. We prepared the calcium. We achieved calcium cracks with intravascular lithotripsy, so it was, I believe, very effective. Now we can look for the pullback which we did from circumflex, which is, I believe, also very interesting. We started at the bifurcation site, and this is the proximal circ, didn't touch yet, but only, this is very important, only dilatations of the balloon in the left main, IVL balloon, and delivery of the IVL energy performed also calcium cracks in the ostium, calcium which is in the ostium of circ, so maybe it will also facilitate our strategy of provisional stenting, we will see. So after this, our next step would be stent implantation. As we mentioned before, we would like to implant 3.5, 22 millimeter long Zotari museluting stent. So we engage the artery with 3.5, 22 millimeter long stent, and we can check, Pavel, with stent boost the position, both the overlap and the ostial position. Give contrast. Okay, doesn't look so bad. Of course, we have overlap by a few millimeters, even more, but this is by intention up to this perforator, and maybe 1 millimeter more proximal. So I will try to remove the guiding, going again with, yes, please. Oh, now it's not bad, not good, so go again. Okay, we can record. Here it looks good, but go to LAO cranial. And you see, in this projection, it looks like we need more protrusion into the aorta. So I pull back a little bit, and again, now check. And this is probably the best projection to do this. We have some movement of the stent forward and backward, so we have to be very careful. Pavel, what do you think?
Perfect position.
Okay, so maybe one small injection to confirm, and you can inflate. 4. It is still in the ostium. 6. And maybe 10 as maximum, not too much. Go to epicaudal now. It's 3.5. Deflate. We will check the ostium of the circ. It's not so bad. I pull back this balloon. And now, please, Pavel, give 16. We will, of course, do, after rewiring, we will do high pressure post-dilatation. But now, not to compromise the circ, 16, 18 with 3.5. And we would go immediately, deflate, with 4.5 balloon for proximal optimization technique. So we need to wait for full deflation of the balloon before we will go back. Otherwise, we increase the risk of stent distortion. Stent in the left main is now 3.5. Of course, the diameter of the vessel is 4.5, so we have to be very gentle with removing of the balloon and not very aggressive with the guiding close to the ostium because we can damage the stent. So I removed the balloon, and we will take another one, 4.5, 12 millimeter long non-compliant balloon. We have our 4.5 non-compliant balloon. I am going to the left main, but here it was not a perfect view to see the origin of the side branch. So maybe we can go to spider. We have this reference, which is not so bad. I will maybe, Pavel, record some injection. Okay, tsick. Okay, maybe a little bit more distal. Okay, but we need to record again. What do you think, Pavel? Looks here is okay. Yeah. Okay, so open. 4, 6, 8, 10, 12. Not too much because we are very close to carina. 12 is enough, and we will go back, and it's very important to cover with this balloon all the length of the stent up to the ostium. So finishing in the aorta, not to have battle-shaped problem. Sometimes we see this, that the stent is not fully dilated. Distally is dilated, but not proximally. So I am going now to the aorta, and here we can give as you wish. Maybe 12, 14, not too much, because 4.5 is a good diameter, let's say. So now we can go to epicranial to see if we opened the stent fully with stent boost. We check the pressure and deflate, Pavel. The balloon is fully opened, and now with stent enhancement, You see that the pressure is going down with every inflation in the left main. Of course, it's nothing strange. But after deflation is going up, so now we will start with check with the stand boost. If we opened the stand, you see, we are not probably in the ostium, so we need to go back again and open it here. And here we can check if we are through the stand. Yes, you see, it's not opened in the ostium fully, so give 18 here in the aorta. So now it's time for stand boost again, and you see that the stand is now very well opened up to the ostium. I will a little bit push the guide, pull back the catheter, and still, of course, we have this trapped wire, so rewiring would be quite difficult. So as we do routinely, we will try to rewire first to this LAD diagonal and then check with ultrasound if we are not abluminal, and then we will try to rewire to circ. So we have our pre-shaped run-through wire. It went with the loop, which is very good sign. However, it doesn't mean that all the time if we go with the loop, we are within the stent, because you can go with the loop through the stent struts and go abluminal. So this is why the next step, as I said before, is to do IVUS. So I have my probe on the wire, and we'll see it goes easily. So let's have a look, Pavel. And we are in the guiding, and then immediately in the stand, which is protruding, but not too much. This is protruding like we like, to cover all the stand, maybe 2 millimeters to the aorta, but we are going from the guiding directly to the left main, which is okay. And now you see the origin of the circumflex, which is patent. You see this calcium, which was cracked. So now we are really sure that we are going with our wire appropriately, and we can try to rewire. We will try to engage this circumflex going from LAD back to circumflex, and let's have a look. It's not easy. I would like to remind you, we have 2 layers of stand there. So first the attempt was not successful. And maybe we can also stabilize a little bit the guiding. This is always compromise between the risk of damaging the stand and the stable position. So I will try go back again. And maybe this particular curve of the wire is not perfect. So going again. Now it's, let's try. Yes. Okay, this looks good. This looks promising. Maybe we can record Pavel. Okay, very tight. And we can go to epicaudal. And if I am successful, we will take as a first attempt, of course, for LAD we need 3-5 balloon, and for diagonal, for this obtuse marginal and circumflex, I would prefer 2.5 as the first attempt, Pavel. What do you think?
I agree.
Okay, so we have to be very careful trying to go more distal, if only possible. Okay. This was not easy also before, but now it's okay. And we will not release this wire which is trapped, because this will facilitate going with the balloon. So first, 2.5 balloon for circumflex and 3.5 for LAD. So we have 2.5, 12 millimeter long non-compliant balloon already on the wire going to circ, and we have also 3.5, 15 millimeter long in the wire, which is in LAD diagonal. So this is 2.5 balloon. I will try to go through the stent struts to the circ, and it was very easy. It was very nice. And now I will go with 3.5 balloon. Okay, we are in LAD. So it's time to remove the trapped wire, which makes us more happy. Yes, it's done. So Pavel, remove it completely. And now we can a little bit reposition the, now the guiding is going into the stand. We have better support. We are going to LED, we are going, and we can check where we are with our balloon in obtuse marginal test. Okay, this is perfect. So let's open it. First circumflex, 4. Okay, it's deflate, maybe too deep, so let's go back and open it here. 4, 6, 10, 12, deflate. And here, 4, 12, 14, deflate. Now we remember that the stand was not dilated in LAD at high pressure, so please do this 3.5 high pressure post dilatation. (14, 16, 18, 20). Deflate. Okay. Now again 20 on LAD. Perfect. Deflate. We will open the balloon after we established the good flow to both arteries and we have good pressure, stable ECG. So we can open again circ. 8, 10. Deflate and go to spider. It would be better to position the balloons with only small overlap. So let's check what we have now. This balloon in circumflex, as I mentioned, is a short one. Here it looks good. Test. Okay. So open 2.5, 6, and we can give on both 6, 8, 10. Deflate. The balloon moved to the circ, so I need to pull back it a little bit more. No, now. Okay, so give 6. And again open, 6. And now it's much better. Okay, deflate. So I have my 3O short balloon to the circ, and I would like to position it just at the bifurcation. So now, Pavel, definitely we need some contrast. Yeah, this looks good. So open this 3O, and we can dilate again the ostium of the circ. 6, 8, 10, and maybe we can even wait for a while. We have quite good pressure. This damping was due to the opening of the valve. Okay, deflate. And again, check a little bit. I will push it forward a little bit to the car. Yeah. Open here, 8, 10. Okay. Deflate. Now we'll try to do the kissing. So I will pull back a little bit the balloon from the circ and give now on the circ 6, 4. And I will open this balloon, go 6. Okay. So now you see control angel. It looks quite okay, but we went with the probe to the circumflex, and this is the pullback. So you see the ostium is quite okay. It looks like the stent implanted in LAD is covering this calcified part of the ostium, well expanded in the left main. We can see also the ostium of the oh, you can see here this double layer. We have some, Pavel, probably this is some kind of stand distortion. My 3.5 balloon is parked in LAD, and I am going with 3.0 by 10 millimeter long DEB, paclitaxel eluting balloon, and I will try to position it distal marker at the carina level, Pavel, somewhere here and open. 6, 10, 12. And I believe it's 12 is okay, and we will wait for 1 minute, checking the pressure. We have some pressure drop, so it's 30 seconds. Still, we need to wait a little bit. You see that this vessel is quite significant. Okay, we have 6:45, it's enough. Deflate. Okay, this is final kissing for me. 308, 6 atmospheres, deflate. And we will now repeat. So I will check with angio. Where is the distal marker? It's okay. So here we can open to distal, Pavel. Compliant balloon. In the left main, we can give 12, 14, and then go to epicranial, because then we clearly see where is the proximal edge of the stent, and we definitely need to dilate because we have seen on previous IVUS that we have some stent distortion there. So this is very well opened balloon, 4.5, and I will now pull back the guiding and also pull back the catheter and check with stent enhancement if we cover everything. Yes, now we cover, you see? So please open, Pavel, and here I will go up to 18, so we will perform this opening of the ostium of the stent to the aorta. Now we see the circ very well opened and the ostium is covered. You see the wire going from the circ to left main. Again, very good lumen. And now we need to check the proximal endosteal part if we have still this double layer of stent distortion or not. I don't see it. And we are in aorta, so perfect result. We did measurements. This is the point of confluence in the distal left main, so the lumen area is close to 12 square millimeters. It's quite okay. Then the distal left main, please, next one. This is distal left main is 1126, and which is also the good area, more than 10. This is big left main, so in the proximal reference, please show us, it's 16. So of course, if you count here stent expansion in the left main is 70%, we would be happy to achieve more than 80, optimally more than 90. But usually left main itself is the tapered vessel. So the diameter of the left main in proximal part is bigger even in normal artery. So I believe that we can accept this result as a good one. We did high pressure post-dilatation with 4.5 balloon. And we also corrected the stent distortion. So this looks okay. We also checked the LAD. And in LAD, we have 7.4 square millimeters. I believe also acceptable result. Previously, we performed the assessment of the circ, which looked good. As let me remind you that we did also drug-coated balloon post-dilatation. So now I will remove the wires and I will do final angio. This is first, and this is the epicranial, looks good. Now we will do spider. Nice. Maybe some linear dissection, but I don't care. We have good flow. We treated this with balloon. I think it would heal. We see this good result also in epicaudal. Again, thank you very much. Thank you to Pavel, Łukasz, and all the team in the CAD lab for doing this complex case. And I hope you will enjoy the rest of the meeting.
Yeah, thank you very much, Jacek, and congratulations on excellent stepwise approach. I need to start by asking our colleagues here in the panel, because we have really a group of expert people, very experienced in left main PCI, to get involved in this discussion. So if someone wants to comment, okay, we go.
Yeah, congratulations to Jacek and his team. Finally, you could achieve very nice result. But what I know, probably not everybody in every cath lab has IVL to treat patients with calcified lesions, at least today. And what will be the option if you don't have such device in your cath lab? Would you use NC balloon with very high pressure, or would you go with OPN balloon? This will be alternative, because it's definitely, it was not case for debulking techniques. You can't use here orbital or orbital atherectomy or rotablator. It's just the case for ballooning. And if you don't have IVL, I think OPN will be suitable alternative. What do you believe?
Yeah, I think Andres has a lot of experience with cutting. He published the role of cutting. Maybe Andres can.
Yeah, first of all, cum laude, I understood why you showed this case, and I guess that I would be very happy to show this in our lab. And a couple of points, and I completely agree that in meantime, this IVL helping a lot. And even I'm not so now I'm much more liberal now to put a stent even in calcified environment, because even if you are in big trouble, you can go back with IVL, and actually you can cut this calcium. But Goran, yes, and then of course before IVL era, I would use cutting balloon, and again mostly or close media to media size, because then it works very well, and then you can do, and also to prepare prepared lesion, and I'm really, it is fantastic job done. But what I really want to say is that in meantime we have, especially for younger generation, we have more and more people are saying that yeah, we have DEB balloons and others. What we see here, how Jacek playing with balloons, and it's coming from actually early days, because it's coming actually from plain balloon angioplasty. And then you see how you with balloon can get a very good result. The only thing what this is just a remark, and that's maybe that if you have, for example, if you have 4.5 and you know that you are having a 4.5 in LID, I would start not with 3.5 but with 4, because then with first inflation you are a bit much more closer to final result. This is only but this, of course, this is really minor, and I understand because we are getting a bit older and we are using less and less diameters. but actually, this is, I guess, a point what we maybe need to how to say to counter.
Yeah, thanks, Andres. Before giving word to Pavel, I need to ask Jacek to respond to this comment.
It was great. However, there is always compromise between, the better apposition of the stent in the left main and the risk of the occlusion and the carina movement and the occlusion of the circ, which was calcified in the ostium. Definitely there was a plaque. Your strategy, which you proposed, and we have, to be honest, used in the past before the era of POT, was that we used oversized balloon stand with very low pressure. So maybe we can go back with this approach,
yeah, but
which is a smart idea.
No, but that's why I'm saying, because the problem is that you use less diameter, you can keep open, but then end of the procedure you for sure will go for bigger balloon, and then you can do the same actually in the end of the procedure, which sometimes is not very favorable.
Yeah, Andres, I have to answer. You said we disagree. We don't disagree. I just said this kind of angiographic improvements can be done with IVUS as well.
Absolutely.
So longer inflation time, you know, from proximal to distal, this does not apply only to angio guidance. So
I say it's friendly disagree.
Okay, Pavel, you wanted to comment?
First, I would like to thank you for this great review of the current studies on the current technology for left main bifurcation and stenting. We learn a lot from all kind of imaging, and of course sometimes we may decide that QCA may be enough based on our previous experience, having done many IVUS or OCT studies. But this is crucial, our experience from all kind of imaging. So we learn a lot about geometry of the lesions, optimization, but I believe we miss one thing, a very important one, related to technology of the stent structure, radial forces for different stents. We did a lot of studies about what is the best imaging strategy for left main, how we should post-dilate the lesion, the stents, one or two stents or more. But still, I believe we should more concentrate in the future on the selection of the stents. We have a lot of stents with very thin struts. I believe they are not optimal for left main stenting because of the lack of radial strength. The geometry closed versus open cell technology, that's very important. We had excellent pictures from in vitro studies showing how the geometry of the stent changes during post-dilatation and pot and kissing. And we see still that we lack a proper geometry maybe still we should concentrate on designing of the optimal stent for left main and left main bifurcation.
Yeah, this is a great comment, and I fully agree. And we really learn a lot, and we refine the technique based on bench, but we need to document that in vivo, in human. And I really like the concept of a number of connectors, 2 connectors versus 3 connectors, and radial strength, as you said. And 20 years ago, I remember when I worked with Antonio Colombo, when new generation of thin struts was available, he says, okay, I put this thin strut and then I go with one strong 3-connector link in order to oppose fully and provide radial strength in the osteum.
And based on also the bioresorbable scaffolds, we learn about recoil, and we have the same recoil with the metal stents, but we don't concentrate on that. We don't observe it during the time, and I believe we should more concentrate on that aspect.
And this is very important in discussion. However, you know, the choice we have now is it's not a big, a number of different stents with different strut thickness. We have 60 to 80 microns. So this is why I believe lesion preparation is crucial. And my decision was mostly driven by the fact that if we use very high pressure balloon, then you very often achieve non-controlled dissection, which is going towards SERG, and then you immediately go for 2-stent strategy. This is first. With cutting, this is very effective, but for superficial calcium. And the IVL is the only one which can also modify deep calcification. So this is why we try to use this more and more often. We know the limitations, economical limitations, but I am really sure that in the future they will be somehow overcome, and we will use more and more of this technology, which is very easy to be used without learning curve and very effective. Thank you for.
Just one.
Okay, just last comment. We need to proceed. We have 2 more lectures. So.
Okay, thank you. Thank you very much. I would like to congratulate the case and the excellent results. I would like to underline the role of IVL in this case, especially in the lesion when the diameter of the artery is quite large and the rotablation it's not enough for this type of lesion. We observe that type of lesion very often, especially in the left main, and we are thinking how to modify the lesion. And as we can see, also it modified the ostium of the circumflex artery. So it was great result, and and therefore we could use the drug-coated balloon also in this type of lesion because it was well prepared. Because we know that the result of drug-coated balloon it's also dependent on the good preparation of the lesion. So thank you.
I believe that there was a lot of concerns about the safety of the use of IVL in left main because we need to do multiple inflations, and of course we need to wait for around 15 seconds to deliver 10 pulses. But usually this is well tolerated by the patients. So, and if we have hemodynamically compromised patients now with low ejection fraction, we usually use support from left ventricular assist devices, so then we are absolutely safe.
Yes,
okay, so thank you for this discussion, and we need to move on. And the next lecture is very, very important. Maciej Lesiak will talk us about techniques to preserve access to the side branch during stepwise provisional stenting. This would be the summary of the key recommendations from the 17th Consensus of the European Bifurcation Club.
Thank you, Jacek. Thank you for the invitation. I completely agree the side branch is the most important because if there were no side branch, there would be no bifurcation club, no this session. So yeah, okay. So let's go to the side branch. I have no any potential conflict. So first is the side branch relevance. So before we decide what to do with a side branch, we have to stop and think, is this side branch worth protecting? And there are a couple of, you'll find it in this paper, a couple of features that make the side branch important. The length is very easy one. If it's more than 7 centimeters, in most of cases, it supplies more than 10% of myocardium. We have the SNU score when you have the reference diameter, number of side branches. The general rule is the less number, the fewer the side branches, the higher the importance of the side branch. So if you have only one diagonal or one obtuse marginal, in vast majority of cases, it will supply more than 10% of myocardium. Then the second issue is what is the mechanism of side branch compromise, and it can be a plaque redistribution during the balloon or ballooning or stenting. It can be a carina shift, but the most important thing is our mistake, which is just implantation of oversized stent into the main vessel, as you can see here on this picture. So we should keep in mind that the most prevalent cause of side branch occlusion is this oversizing of the main vessel stent. So what to do to prevent losing a side branch? Very easy. Just drop the wire down the side branch and keep it all the time during the procedure. It's not only changes the jade wire, not only changes favorably the anatomy, so make it easier to access to the side branch after main vessel stenting. It can be used also a kind of anchor after main vessel stent implantation and post-dilatation. And what is perhaps the most important, this jade wire can be a rescue tool. Yeah? So using this wire, and I will show you this in a few minutes, you can use this wire to rescue the side branch, and it's in most of the cases it is really possible. We have some clinical data. This is one of this of data that wire jailing at side branch is the best way not to lose the side branch during main vessel stenting. So putting this into the other way, the easiest way to lose side branch is just not to protect it, to implant the oversized stent, and you can clearly see that you see the immediate result of losing a quite large diagonal branch. So as Jacek mentioned, the 17 expert consensus of EBC is just dedicated to this topic, the techniques to preserve the access to the side branch during main vessel stenting and what to do. So what are the preventing, not only preventing measures, but also how to rescue the side branch if you lose it. So first, there are some risk factors. We know those risk factors that make it more easy to lose the side branch during the procedure. The plaque distribution, if there is more plaque around the takeoff of the side branch, the risk is higher. The reduced TIMI flow at the side branch in the beginning of the procedure, the severe diameter stenosis of the bifurcation core, but also the side branch itself, the unfavorable angulation, the bifurcation angle, the ratio of main vessel to side branch diameters, two or more, diameter stenosis of the side branch, I already mentioned it, the spiky carina, something that was already published many years ago by Medina. If the carina in imaging is very spiky, it's more prone to move towards the side branch and compromise the flow. You can also use the special resolve score, which is nothing else, just putting all the features together like plaque distribution, TIMI flow, diameter stenosis, bifurcation angle, the ratio of diameters, as well as the diameter stenosis of the side branch itself. Of course, the higher the stenosis, the greater the risk of side branch compromise after main vessel stenting. So first, what are the techniques to wire the side branch? Because sometimes it's not very easy. In most of cases it is, but in some cases it's not easy. So we're starting with pre-shaping the wire. Sometimes we change the wire into polymeric hydrophilic wire. Then we can use dual lumen microcatheters with deflectable or angulated tips. Then you can use the reverse wire technique. I will show you how to do this. Sometimes we have to pre-dilate the side branch. We don't like it, but sometimes it really helps. And sometimes to remove the high plaque burden at the takeoff of the side branch, we use some ablation techniques. So this is one of the example, very unfavorable takeoff of retrograde takeoff of the circ. So after rota of the LAD, left main LAD, I used the angulated microcatheter, and then I was able to deliver a Fielder XTR wire down the circ. This is another example, very complex lesion of the LAD diagonal bifurcation. Actually, the problem here was to access the LAD, because look how the wire would need to be pre-shaped to get the access. In this situation, because the wiring diagonal was easy, I used the reverse wire technique. So the wire, you bend the wire 180 degrees, and using dual lumen microcatheter, pulling back the wire, I could access this LAD in this time. But in most of cases, we use this technique to access very unfavorable takeoff of the side branch. So once we wire the side branch, we prepare the lesions and we stent the main vessel. So what can we do apart from jailed wire to protect the side branch? You can use, you can jail not only a wire, you can also jail a balloon, you can jail a semi-inflated balloon, but you can also jail a microcatheter, and then to make it easy to rewire the side branch. There are some preliminary maneuvers you should do before attempting reaccess to the side branch. Of course, I already mentioned mentioned, you should leave the wire at the side branch during main vessel stenting. Then, of course, pot is very important. Otherwise, it's very easy to get your wire under the struts of the main vessel stent, because we choose the stent diameter according to distal, not to proximal reference of the main vessel. Sometimes, if you spend 20 or 30 minutes wiring the side branch, it's better to start with side branch stenting, so you convert your thinking, your philosophy from single to two-vessel stenting. And as I already mentioned, balloon predilatation is also one of the solutions to make it easier to rewire after main vessel stenting. So once you stent this, you put the stent. Again, if you have problems with wiring the side branch, a couple of techniques, starting with guide wire tip configuration, changing a wire. Sometimes we even use, not very often, but we even use CTO dedicated wire. Sometimes repot works, because then you stretch the cells and you enlarge the access to the side branch. And of course, you can, if you cannot do it and you lost the wire, you can use, as I mentioned already, the jailed wire to rescue the side branch. So this is how to do this technique. So you jail. So you see the situation when the violet wire is jailed at the side branch. In most of cases, you can deliver a low-profile balloon over the jailed wire. If not, you can use a microcatheter. The Corsair is a very good microcatheter here. But now, before you inflate the balloon at the side branch, put a main vessel balloon, because this is very important, because with this, with inflation of your balloon at the side branch, you will deform the stent. So to avoid any complications regarding the main vessel, you should park your main vessel balloon before this. Then you can safely open the balloon at the side branch, and then you can do the pot again a little bit higher, not to move the shift carina towards the side branch. And in most of cases, you can rescue the side branch this way. If not, the last resort is just to invert your strategy from provisional to inverted crash. So you follow the same steps. So you are passing back the small balloon. You crash the stand, main vessel stand with the bigger balloon, and then you position the side branch stand over the crashed main vessel stand. Of course, you should finalize everything with kissing. So having said this, I will just refer you, due to the time, to this document. You will find a lot of very practical data, what to do before main vessel stenting and how to rescue the side branch after main vessel stenting if you lose it. Thank you very much for your attention.
Thank you very much, Maciej. This is really very good document and very good summary, so every interventional cardiologist should read this article and try to use those tricks in the everyday practice. But for me, the one important message is also, according to what you presented, that if we have a complex bifurcation lesion, especially in an elective patient, before we go for PCI, we should be aware what we have on our shelves in the CAD lab. If we are well equipped with all the devices you presented, dedicated wires, microcatheters, it's not only that it's not enough that you know the techniques, because if you have no devices in the CAD lab,
but the simplest
it's not possible to
jail wire technique is the easiest.
This
and
is,
works
of course, for every
cases.
bifurcation. Thank you, Maciej. Excellent. And at the end of this session, we have asked Professor Bernardo Cortese from Milan to deliver the lecture on the very hot topic nowadays. So we are going back to plain old balloon angioplasty, but now with drug-coated balloons. And we asked Bernardo to present how he used it also in bifurcations and especially in left mains, because this is very important. We presented the recorded case when we used this technology to treat the side branch, which is discussed for years, but there are also cases presented without stenting in the left main. So Bernardo, we are really thrilled to hear your lecture.
Yeah, good morning to everybody. Thank you, Jacek, for the presentation and the invitation. Yeah, I will try to go through a little bit, which is the evidence on the use of drug-coated balloons for side branch. I would say that this is not the strongest evidence that we have so far with this technology, but some important informations are being added to the literature and also to the technical skills that we are having. But first of all, I would like to start with an important information that, of course, you all know, that the more complex bifurcation we face with two stenting strategies, the worse is in terms of clinical outcome for our patients. And this is quite true also in terms of mortality if we take into account information taken from this meta-analysis, which is showing how a two-strand strategy is associated on the short term, but also on the long term to an increase in mortality, 6.2 versus 4% with a provisional stenting strategy, which is currently the strategy which is suggested by EBC in the majority of our bifurcation patients. And we have also some patients with only a single 0.01 Medina, and we recently published with many colleagues from Poland as well, this study showing how here in this very complex subset where we don't know what to do, two-stent strategy is similar to one stent. Unfortunately, in this study, the drug-coated balloon possibility was not taken in account. Drug-coated balloon is a technology which allows a rapid drug delivery to the vessel wall. In the case of paclitaxel, associated with lumen increase in about 2/3 of the cases. And what is important is that, as you showed in your case, if you leave a dissection with a good flow, this is not an issue, because it is also better, at least for paclitaxel, because it helps the drug to penetrate better into the vessel wall. And 8 years ago, we have shown how leaving a dissection after DCB angioplasty is absolutely safe if we leave a type A or type B, few type C with a good TIMI3 flow, because in the vast majority of the cases during control angiography, the dissection do heal, and we had 0 cases of acute or late closure during the 1-year follow-up after dissections left. In the case of paclitaxel, but also, as we recently showed, also in the case of sirolimus-coated balloon. This is a sub-analysis of this study showing how a dissection left after sirolimus-coated balloon is not associated with an increase in adverse events or in late closure of the vessel. And this is also a quite reassuring information. There are few studies on the role of DCB in bifurcation, which is today's topic. Actually, the majority of these are only small trials. In the last part of this presentation, I will try to give a glimpse on the next future, which is larger type of study with clinical endpoints. But these studies, starting back 12 years ago, started giving us some important information on the role of paclitaxel and only later sirolimus-coated balloon for side branch management, mostly. The PEPCA-BIF study showed how the late lumen loss with the DCB used for the side branch was significantly better than a POBA in the side branch. Late loss was 0.13 versus 0.51 in the POBA group. And we also have this information from a similar study, which, however, compared two-stent strategy versus drug-eluting stent in a main vessel versus drug-coated balloon in a side branch, and look at the immediate post-operative luminal stenosis, how it is better with stent, which is something that is good for our eyes. However, if you look at the outcome during angiographic follow-up, late loss in the main vessel is the same, but in the side branch, DCB minus 0.17 versus 0.43 in the two-stent. This is the area where a two-stent strategy is associated with a worse outcome. We have good outcome in the main vessel, but still in the circ, in the case of left main, or in the side branch, putting too much metal there with complex techniques is not associated with a good angiographic outcome. And what about the comparison for the left main specifically? Quite the same information. Here we have lower late lumen loss, 0.09 versus 0.17 in the two-stent group, but also lower target lesion revascularization, despite it is not significant due to the small sample size of this study. Another meta-analysis, which was published a couple of years ago, actually last year, is showing how putting together all of this information quite clearly, we have an advantage in terms of late lumen loss for a DCB versus the POBA for the side branch management, but also as regards TLR. We have a significant reduction in TLR for the side branch management. So I would say that using a drug-coated balloon in these studies, only paclitaxel-coated balloons have been used, is a good alternative to complex dual stenting. And of course, it is much better than using a POBA in the provisional fashion strategy. This is another study that is, I would say, quite interesting, which is showing how the usage of paclitaxel-coated balloon in the main vessel, only in the main vessel, is associated also with an improvement in the late lumen loss in the side branch, due probably, and this is only a theory, I would say, the release of the lipophilic drug, which is paclitaxel, into the side branch. So it's quite interesting at 9 months, showing how in all of these Medina type classifications, there is this quite nice outcome. And very recently, we published another sub-study of this study, the Eastbourne beef, with Magic Touch sirolimus-coated balloon, showing how the performance also of sirolimus-coated balloon is quite reassuring, also for the management of side branch. We have no clinical difference in terms of TLR, all-cause death, spontaneous MI, in bifurcation management as compared to the de novo lesion subset. The big limitation of this study is that this is only a post-hoc analysis of a prospective registry, and we are putting together all of the strategies for using of DCB for the bifurcation management, including full DCB or hybrid with the main vessel stenting and DCB for the side branch. But it's an initial important information that we would like to have. Now I'm going to show you a quite complex case that we decided to manage with a blended therapy. This is a distal left main complex and diffuse disease of the LAD, with also the circ, which is diseased. We did predilatation, I would say a moderate predilatation with a semi-compliant balloon, just to see how was the result. And we used scoring balloon. We did OCT analysis, and then according to the findings of OCT, we started using larger balloons. We predilated with semi-compliant balloons 3O at quite high pressures, obtaining these. So we had a good lesion preparation for the left main. We implanted a stent there with a nice result. Then we did a dilatation on the circ. At that time, we used only POBA, then kissing balloon with 2 POBA with the left main and the circ. We did a POT for the left main. And then we had to still to manage this proximal LAD, which was highly calcific. Then we used 3O non-compliant balloons at high pressures, and this was the best that we were able to achieve here. We didn't use IVL at that time, but we used a drug-coated balloon, which is much safer if we don't prepare the lesion, the calcific lesion, perfectly for stenting in our experience. So we used a 3/30 sirolimus-coated balloon, 2 of them. Then we did the final OCT assessment. And this is the final result with this dissection here in the proximal LAD, which had a good flow. The lumen was good also at the OCT. So we stopped there. Then we have the 6 months control angiography, which is showing how the dissection was nicely healed here. We still have this first diagonal disease, which we didn't treat, and we also have some disease in the with recoil, which is quite typical after POBA in the circ. So what we did here, we use a drug-coated balloon also for a diagonal branch, obtaining this result. And then at this time, we decided to deliver the drug also in the circ. We treated all of the circ with predilatation, with semi-compliant balloons, 2.5 distally and 3.0 in a proximal part. This was the result, good result. Then here we can deliver the drug. And here we use a kissing balloon with a drug delivery in the ostium of the side branch and a normal balloon in the left main, obtaining this result. So a two-step, two bifurcation strategy for this patient. The future, very briefly, we have designed a Piccoletto 5 trial because we want to see in non-left main bifurcation if there is a role for a full DCB angioplasty versus a provisional stenting. So native non-left main bifurcation after correct lesion preparation, we can use whatever we want, but we have to achieve this. Final stenosis less than 30% and no dissection more than type B and good TIMI flow here, we can randomize the patients to EBC-like provisional stenting versus full drug-coated balloon where we also test the two potential strategies of simultaneous kissing balloon inflation or sequential DCB inflation in the two branches, because so far we don't know which is the best strategy. Obviously, we can also accept the bailout stent based on the result. And then we will have a primary endpoint, which is a 9-month CT scan FFR, which will be assessed by the core lab. This is my team of fellows of DCB Academy, which is helping us in delivering good clinical data about drug-coated balloons, and not only, but what is very important is that the momentum of drug-coated balloon is associated with a very important number of clinical trials assessing the role of these technologies. Specifically, we have these two big trials with clinical endpoints. The first one is already ongoing, having enrolled more than 300 patients for a bifurcation, provisional stenting with POBA versus provisional stenting with a drug-coated balloon. And also we have the Piccoletto 5 that I just presented you. So thank you for your attention.
Thank you. Thank you very much, Bernardo. I believe that it was very good talk at the end of this session at the New Frontiers in Interventional Cardiology meeting, because this is definitely new frontier. Old technology of balloon angioplasty or old technique of balloon angioplasty, but with different balloons. And going beyond just the treatment of the ostium of the side branch, just to fully balloon angioplasty even for left main. So this is amazing. And however, of course, we need to take into account, and we are just doing some research on that. And this should be probably now limited to the trials, to registries, not everyday practice. However, to treat the side branch, everyday practice is absolutely possible and supported with data. Darek has a question.
So, thank you very much for this great session on Bifurcation Club, but I think that I will wake you up. So I have two questions. So first, I am the part of this Bifurcation Club, but I have no time to attend over last meetings, but I did approval because many years ago for the CTO Club and Bifurcation Club to make the society to educate people. And for the last years, you are saying that two stents technology are the most important. And now I see that you are rather the imaging technology bifurcation club and also balloon-based like DCB. So what happened, Goran, that two stents technology are not so powerful and the study were not so successful? Is it a problem with technology or technique? And the second particular question on your consensus, when you say that you want to automatically upsize the angio QCA, I think that it could be dangerous in the mid LAD when you have 2.53 millimeter diameter and you go 10% more, it could be a risk of perforation for many arteries in mid-LAD after the first septal branch and first big diagonal.
Yeah, thank you, Dariusz. Of course, great comments. Why not routine two-stent strategy? Because first meta-analysis from 18 studies showed that at 5 years of follow-up, there is 30% higher mortality with two-stent strategy compared to provisional. Then we publish Nordic 1 and BBC 1 again at 5 years and 10 years of follow-up. We have again significant mortality difference, total mortality, and Syntax 10 years of follow-up replicated that one. So
no, this is the data I know. I'm asking, why do you think that it happened?
why did it happen?
Yes.
We don't have clear answer, but what we strongly believe is that fixing the bifurcation and inadequate expansion and lot of metal at bifurcation site changes the pattern of flow, increasing thrombogenicity. Because the only study in the left main that Renu Virmani published showed that predictors of left main stent thrombosis are 1, malapposition in the polygon of confluence, and 2, struts across the ostium of the circ. We don't routinely do kissing, and we don't really use all the technologies to optimize expansion. This is probably one of the reasons why two-stent strategy with lot of metal unopposed in the polygon of confluence change the flow. Plus, you have with two-stent strategy change in bifurcation angle and restriction of movement during systole, diastole. But we don't have clinical evidence for that. This is why we say when you need, it's okay, and it's approximately 1 out of 5 patients. But if you do it, then you have to do it with kissing, high pressure inflation, and if possible with image guidance.
Do you believe that in the next 2, 3, 5 years, will we come back to two-stents technology with newer stent technology, or you think that it's rather end of the story and it will be more imaging and more the balloon?
Yeah, I think that convincing evidence exists that with optimized treatment, with good expansion, with less metal, provides better clinical follow-up.
This was maybe very good discussion at the end, that of course there are still some doubts, and we do not forget about two-stent strategy. However, this year, we extensively discussed last year. This year, we would like to remind you that the best strategy for majority of patients is just single stent implantation. However, all of you interested, you can even test in the bench test during this meeting how to do appropriately two-stent strategy. The problem is that you have to be step by step. You have to know all the rules, and it's just much more difficult to do than just provisional stenting strategy. Having said that, I would like to thank you very much. Thank you to my co-chairmen, to panelists, and to all who attended this, I believe, very interesting session. Thank you, Bernardo. And I hope next year you will be with us, and we will, of course, reserve the special session for you, case review, as we discussed before. And we are a little bit out of time, but I believe that 5 minutes break would be okay, and then we will continue. The next session would be dedicated to integrating of physiology and intravascular imaging with some case presentation. I believe it will be also very, very interesting one. So 5-minute breaks, and we are here again.